It is my pleasure to introduce our next speaker, who is Dr. Nathan Close. He is a clinical and laboratory haematologist in private practice at Greenslopes Private Hospital. He has experience in administering various treatments such as chemotherapy, immunotherapy, and cellular therapies, including bone marrow transplantation and CAR T cell therapy. Dr. Close is an active investigator in bispecific antibody therapy for myeloma. He works with a focus on open communication to deliver expert, personalised care to patients in Brisbane and further afield. And that's why he's perfect to present for us today on My Voice, Shared Decision Making. Thank you, Dr. Close.
Thanks so much, Kath. Just triple checking I'm coming through okay. Wonderful. Technology is great when it works. Thank you so much for having me. It's a real honor, and I think obviously some great quality of speakers, and just really great to assist Myeloma Australia's wonderful work. So thanks for coming, thanks for listening, and especially thanks for having me. I've been asked to talk about shared decision making, and it's something that I'm really passionate about. We've heard about some options already available to you through risk assessment, and hopefully this just continues that conversation about shared decision making. And I thought I'd start by relating a quick story and start with some AI generated feet, which you can tell because the toes look really weird. This is represents a patient of mine that I had when I was a junior doctor in training, and this fellow was elderly. He had medical problems, including heart failure, a leaky valve that didn't work, and had an awful infection on his toe. And it wasn't responding to antibiotics, and it was getting to the stage where we'd have to do an operation to chop off his toe and probably most of his foot to save his life. But unfortunately, because of his medical problems, that sort of operation would be a life-threatening operation, and there'd be a decent chance he wouldn't come through. So just an awful rock and a hard place kind of situation. And as a junior doctor, I was mainly responsible for running the ward and looking after this fellow. And we just couldn't come to a decision together. Should we do the operation? Should he not do the operation? And we go back and forth about, like, should we pull the trigger, get the surgeon in and do it or not? And it wasn't until a very helpful nurse came by one day, and I overheard a conversation, and they were speaking about his dog at home, and we spoke a bit more, and it got me to asking, rather than do you want an operation or not, I asked him, well, what are your goals? What actually is really important to you going forward in the next couple of months? And it turned out his poor dog's being looked after by an elderly neighbor. He wanted to get home and see his dog one last time and take him to the beach if he could. He wanted to get some paperwork sorted at home, so his will and some other things that he needed to get sorted at home. So really what was important, that he could get home for a couple of days. And then if he didn't survive in the next few months, that was okay. His quality of life was decreasing. So it just completely changed the conversation. Rather than asking a medical question, do you want surgery? It came to asking a different sort of question: what's important to you? And then how could I make a medical program that kind of met those goals? And perhaps that should have been more obvious to me as a doctor throughout training, but for me became very clear that my role is not to administer treatments to diseases. My job is to look after patients. And so a key part of that is finding out what's important to people, and using our expertise as doctors to make a treatment plan that meets those goals, rather than treats a disease in a particular or arbitrary sort of way. So that's a bit of my background and why I'm so passionate about that. And I bring that sort of philosophy to the way I look after myeloma. Just a couple of quick disclaimers. Obviously, you're well aware comments regarding myeloma and their different treatments are general and may not apply to your situation. These are my opinions. This is not the best way to practice medicine or myeloma care. Your doctors, you and your loved ones may disagree, and that's okay. And shared decision making, as you can kind of tell by that little intro, it does involve some really big and difficult questions. Sometimes it's easier to ask, do you want lenalidomide maintenance or not, versus, what's important to you. Those are really tricky and big questions, and can bring up some really confronting sort of future sort of issues. So do the journey with your support network. That includes your family, it includes your GP, and make sure you seek help along the way. So in this quick talk, I'm just going to aim to cover 4 questions. We'll spend some time on the first 2, why shared decision-making and what is shared decision-making. We'll run through some practical things about how you can prepare for shared decision-making with your hematologist, and how do you kind of get the ball rolling and get engaged if it's not already happening. So in terms of just making a case for shared decision-making, well, of course, I wouldn't be a hematologist doing a presentation if we didn't get some evidence in there. So just starting with, shared decision-making is when we do patient-centered personalized care. So this is care based on what's important to the patient rather than a disease-centric focus. There's some good quality evidence in this space, but this is one particular paper focused on multiple myeloma. And there was some evidence that it resulted in increased patient confidence, satisfaction with the treatment decisions, increasing trust in the healthcare team, increasing treatment adherence. Obviously, you're more likely to take the medication and continue taking it, not forget it if you realize why it's so important and why it meets your goals. Improved health quality of life was common, and even a signal suggesting an improved physical health outcomes. So these are, it's not just a nice idea, but it's a good medical option for care that results in improved outcomes. The stakes are high. We are dealing with, at the moment, an incurable disease, and the journey is long. The options are complicated, and I just don't see any other way to do it. Shared decision-making is, in my opinion, the only way to manage this disease, given the trajectory that we face together with it. So what if I say it's the only way of doing it, well, what are some other ways of doing it? And in terms of approaching your medical appointments and your medical care, I've kind of created this sort of spectrum, which is a bit arbitrary, but it hopefully gets the point across. And at one end of the spectrum, you've got a completely autonomous, self-directing patient. I guess at a real extreme, you've got a patient who doesn't even see a doctor. They've made their own decisions for their healthcare, and they'll figure it out. Or if they're engaging with a doctor, they're going to tell them what they're going to do after Googling. And then at the completely other end of the spectrum, you've got an authoritarian healthcare provider. There's no exchange of information. They're here to deliver the treatment plan to you, and your job is a passive participant in that process to say, yes, doctor, and do what is given to you. So shared decision-making sits within this spectrum. And obviously there are preferences that you or your specialist may have one particular way than the other. As a personal note, I sit a lot more towards the patient autonomy end of the spectrum. I love engaging with my patients and helping them make a decision, not to place the burden of them, but so that they feel empowered with the decisions that they're making. But shared decision making is anywhere within this spectrum. The other reason why shared decision-making is important is because, as we said, the decisions are complicated. And just as a really quick summary, this is not quite a comprehensive list, but in terms of the treatment options that are available to us in 2025, of course, highlighting clinical trial participation. In terms of PBS reimbursed medications, we've got several triplets. We've still got autologous stem cell transplantation, multiple lines of novel agents available, not including the chemotherapy salvage options. In TGA approved, but not PBS reimbursed options, we do have several, and including the cilta-cel, which is sort of obviously progressing in its PBS or at least federal funding reimbursement status, as well as multiple bispecific antibodies. We do have future therapies coming, and you'll hear more about them, at this conference and elsewhere. But essentially, we've got a lot of options to choose from. Now, what that means is 2 things. One is we need to engage with our patients to help decide about them. But the other is you're going to need your specialist help. Honestly, we do our best to stay on top of these things ourselves, but from a realistic point of view, it's going to be very difficult for even an expert, myeloma patient to try and keep up with what's going on, because there's a lot going on. So why shared decision making? Your healthcare team should be the experts in the myeloma and the treatments available, but they've not encountered you before. You're the expert in you, and as we've heard a lot today already, every patient with myeloma is different. And I guess I just wanted to highlight here, this is more than just the biology of the myeloma, like as in your own case of myeloma, but you're the expert in you. You're the only one who knows what you want. And the treatment plan shouldn't be aimed at treating myeloma. The treatment plan should be aimed at meeting your goals. Without discussing the disease, the treatment options, the potential side effects, assumptions can be made about those goals, leading to mismatched goals and suboptimal outcomes. Everyone is different, and so don't assume that your healthcare knows what you want and what's important to you, and neither should your healthcare assume that they, know what you want and what's important to you. It's especially early on in the treatment course, of course, efficacy and good outcomes, deep responses, maybe, etc. These are very common treatment goals, but they're not the only goals. And thinking about other things that's important to you is a key part of that shared decision-making process. So that's hopefully I've made a bit of a case for why we should be doing shared decision-making. And then this is just a bit of a summary on what that process involved. So in my mind, shared decision-making involves a number of steps. The first step is having an expert healthcare team who understands the treatment, and that's going to include your specialist, it's going to include your myeloma specialist nurses, your other support and information team, including Myeloma Australia. And that's the first step. The next step in the process will be engaging with an expert patient who understands themselves. And that means someone who understands their treatment goals and their personal values. And that's your half of the equation. Now, you can have those two people present in a room, but if they don't share their knowledge with each other, that is not going to be helpful. So the third step in the process is a knowledge exchange. This takes time. So being realistic about some time for education, to be able to learn about your disease, the options available, the potential side effects, but also giving your doctor time to understand you and listen to you, and what's important to you is that third part of the process. Once there's been sufficient time to exchange knowledge, and obviously that's an ongoing process, together you're then able to design a treatment plan which meets the goals. And it's important that that is not done with shortcuts. And I think, just to highlight, some cases that might be examples of what happens if we take a shortcut one way or the other. A classic one is doctors making a treatment plan without considering the patient's goals, and that can result in a reduced quality of life. There was some excellent, just as a quick story, there's excellent data, especially back when we only had doublets available. We were using bortezomib by itself, that the number of doses of bortezomib that you got was directly related to your outcomes with the disease. And so maximizing and using every single dose you could get on the PBS was really important. We had a patient that, unbeknownst to us, was also a concert pianist. When you actually got down and sat and listened to him, he wouldn't mind, 12 months less progression-free survival if he could continue to play his grand piano for his grandson, and making assumptions that a maximized progression-free survival was what was most important to this patient would miss the potential side effect of neuropathy that could occur with progressing doses of bortezomib, and therefore not meet his treatment goal. So that's how doctors could make a shortcut and assume and have a poor outcome. Similarly, it's also possible to make assumptions from a patient's perspective. This is not getting the information that you need to get from the expert healthcare team in order to meet your goals. So making assumptions about side effects or outcomes from certain treatments without actually knowing what the possibilities are. I've have a privilege of meeting a wide range of patients from lots of areas of life and different sort of background health values. And it's not uncommon to come across patients who, before they've even heard about myeloma treatment, will be refusing treatment. So I don't want chemotherapy. I don't want, lose my hair and, this kind of thing. But actually, when you engage with these people and you hear what they want to be healthy. They don't want their health to be affected by, this or that, or they're worried about particular side effects. And so when you can run them through what to expect on treatment, you can actually come up with a treatment goal that aims to try and maintain their treatment plan. And you can aim to meet their goals. And you'll find out that their shortcuts they're taking by refusing treatment and not understanding about them is actually not meeting their goals worse than if they were to receive the treatment, which would actually maintain their health in a better way. So just to highlight a couple of pitfalls if we don't do shared decision making. So hopefully I've made a bit of a case to you about why we need to do shared decision making and then what it involves. In terms of participating in the shared decision making process, first I'll talk about some aspects that you can do to prepare. The first is not an easy one and one that, I do recommend you do with your loved ones and other support network, is taking time to think about what's important to you. And this may be, fighting the myeloma with everything you've got, putting up with any potential toxicities to get the deepest and longest response possible. But there may be some other things that come up in that conversation as well. This also includes what quality of life means to you. And again, these issues take on a bigger role as we progress in the myeloma journey and deal with people later on in the course with relapsing disease. But, quality of life it is different to different people. And that includes potential side effects, independence, and other things. Really being honest with yourself and asking the question, does treatment effectiveness and quantity of life really trump everything? And are there more important things in life than, squeezing every month of progression-free survival out of a treatment that's possible? And I've just, given some examples here, but are there certain activities, lifestyle considerations that are important to you? And that might be, being able to continue to work, taking time off to travel, having time off treatments for other reasons, and side effects that in particular may affect hobbies and passions. Finally, is just, it's an incredibly vulnerable position to come to an appointment. There's the stress of receiving your results, the results day anxiety. There's the anticipation of the treatment and other side effects that might go on in the day. There's the busyness of hospital parking and all of that. But just being ready and set in your mindset that, as we heard just before, we're here for you. There's nothing more important on our day as your myeloma specialist than coming and listening to you and hearing about what's important to you and your treatment goals. So being prepared in your mindset and in your attitude to ask questions about the treatment plan and mention those things about quality of life is something that you can just mentally set yourself for coming to your appointments. When you're trying to start that first part, either at diagnosis or facing a relapse and a change in treatment, there is a bunch of information that you need to know about the treatment in order to know if it's going to meet your treatment goals. And this is all information that your healthcare provider and the myeloma support nurse, etc., should be able to provide you with. We won't run through this in great detail, but just some high points. How effective is the treatment expected to be? How long before we might need another treatment? What's the chances that it might respond at all? How is the treatment given and where is it given? At home, in the day unit, tablets, injections, infusions. What's the treatment schedule? Do we have times off? Is it continuous until relapse, or is there a defined period and then it stops? What are the expected side effects and what are the possible side effects? How can I expect to feel whilst having treatments? Can I take a break or miss? What happens? So what comes next? What happens when the treatment stops working? And is this clearly the very best option, or is it equivalent to potentially other options? And should we be weighing up multiple options together? So having taken some time to prepare for shared decision making and think about the type of questions that you need to know and the informations you need to know to engage in that process, I thought I would just highlight a couple of practical points about how do you actually start in this process, because I do acknowledge, like I said, it can be difficult to get the ball rolling if that's not how you feel the conversation has been up to this point. And I will say the main responsibility rests with us. We're humans as well, and there's busy clinics and the stress of dealing with stuff. It's no excuse. As we've said, there's nothing more important about the care we provide than you. You are the reason why we're doing this, and we're not treating your myeloma, we're treating you. We have a saying at Brisbane Blood, which is what matters to you matters to us. And the key onus is on your healthcare providers to set that tone and get the ball going. However, you also are there and need to prepare and engage in that process. And so taking the time to prepare is a key part of what you can do. The other sort of thing that you can do to assist in this process is to bring your support persons with you to the appointment. As I said, it can be hard to remember your list of things you've got to get done for the day, and having that extra brain with you can help engage in that process a bit better and be a bit more of a advocate for you as you engage in that process. And finally, as you can tell, these things take time, and from a really practical perspective, sometimes not every appointment will we have time to discuss all of these issues. So just flagging with your healthcare team in advance that there is some bigger picture stuff that you need to that you'd like to engage with. If you are in the public system and that you're dealing with registrars coming or junior doctors, and then you've got other times where you're seeing the consultant, trying to flag with the team that you've got some bigger questions to run through just prepares them so that they've got the time to allocate to you if possible. Yeah, just to reiterate this point, to feel empowered, we're here to treat you and your myeloma. So that was it. That's all I had to run through today. Sorry, very intangible sort of talk, not a lot of data on myeloma and its treatment, but hopefully some thought-provoking things and just something to empower you and make you think that you are the reason why we're here, and this is a long and complicated journey, and one size doesn't fit all, and the only way I believe to get through it is to engage with your team and help make those decisions together, and that way try and meet your treatment goals as best as possible. So that was all I had. Thanks very much.
Thank you, Dr. Close. That was amazing, and I'm really sure that our members will find that very empowering. I'd like to probably just remind, which you did in your talk, thank you very much, but in terms of being prepared, on our nurse support line, we do have the benefit of time that your specialists and even your nurses in the day unit sometimes don't have. So please book a call on the support line. and we can talk through some of those concepts. What are your values? What are your goals? What can you expect from treatment to try and help you make those decisions, and then go into your appointments armed with that information and with a little bit of that up your sleeve. I'm not sure if you're happy to kind of answer. It's a question in a roundabout ways, almost like a case study, but we had an inquiry from a lady in WA who was diagnosed back in 2019, had CVD as her initial treatment and had a partial response to that. 6 months along, numbers were moving, and she went on to DVD at that point and has remained on that, on maintenance daratumumab, up until now, where now her numbers are increasing again. And her question was sort of, where to from here? And I thought this might be a nice point for you to maybe say, like, how might she approach that
Yeah.
discussion?
Yeah, that's a really it's a perfect scenario that incorporates, clearly we've got all the medical information there, and no personal information. So my first approach would be to find out where this lady's living, how close she is to the day unit, how easy accessible infusional medications are, because we've got a couple of options that we'd sort of consider. But basically the conversation would be around a lenalidomide backbone medication regimen that would either incorporate elotuzumab as a infusional medication along with the lenalidomide, or carfilzomib being KRD, the other protocol. So we'd approach this by looking at the data together. It's going to be difficult to compare those trials head to head because they are very different settings where they were the registration studies for those two trials. But talking about the expected efficacy, and I'd be really positive. I've had a lot of people do really well with lenalidomide-based therapies in these non-len exposed people for third-line therapy. So be really positive approaching that conversation, and then talk about elotuzumab versus carfilzomib, what to expect when you're on those infusional medications. But both of them are IV. Elotuzumab's fortnightly, carfilzomib's in the KRD regimen is twice weekly. So that's a lot of hospital contact. There's maybe comorbidities with heart stuff we'd consider with carfilzomib. So yeah, a wonderful example where we then sit down, run through what's important, like hospital contact times, particular side effects, and then run those efficacy numbers together and see if we can match all that together and make a decision. But there are other treatment options as well, but those would be my two picks.
Yeah, perfect. Thanks so much. We'll get that information to her. I'm sure she'll watch today as well. Thank you so much for your time and for a wonderful talk. Thank you.
You're welcome.